as our speakers at Club EvMed, presenting as a panel. I don't know what their roles are going to be in terms of who's presenting and all that. But we have Damon Reed, who's an oncologist at the Moffitt Cancer Center. He focuses on pediatric and adolescent patients. We have Chung, and she's also an oncologist. She focuses on HPV and its role in cancer in terms of her research. We have Joel Brown, who's an ecologist and evolutionary biologist. He's also working at Moffitt. He's had a distinguished career as an ecologist, and he's been turning his attention for many years now to the challenge of cancer and thinking about how to model cancer mathematically and to bring ecological and evolutionary perspectives to understanding and treating cancer. And then we have Mark Robertson-Tessi. He's a research scientist at Moffitt, and he focuses on tumor immune interactions and on cellular metabolism, among other things. And so the four of them are going to give a short presentation, and then we'll open it up for discussion. So go ahead, guys. Thanks for joining us on Club EvMed Conversations.
Good afternoon. Today we're going to talk about Moffitt's Evolutionary Tumor Board. So I will start the talk, but four of us will tag team as we go through the slides. Next, please. So tumor board is a quite familiar concept to the clinicians, but evolutionary tumor board is relatively new, even among clinicians. And I recognize that the audiences come from all different disciplines. So I decided to go through frequently asked questions. So first one is, what is it? Why do we do this? Who needs it? Who attends it? How it gets conducted? How to generate ideas? And when is it? So next, please. So basically, it is a forum to develop ideas to apply the principles of eco-evolutionary dynamics into cancer treatments. Next. So the goal is to provide evidence-based treatment recommendations to individual patients in need, and basically serves as a think tank to generate innovative research ideas and investigator-initiated clinical trials through multidisciplinary interactions. Next. So why do we need it? As a treating medical oncologist, we have too many patients with no treatment options. And all our treatments are very limited in its efficacy, and the toxicity is simply unacceptable. And majority of clinical trials fail to show improved survival and decrease toxicities. The reason is, as all of you know, cancer is a dynamic ecosystem. But the way that we view our cancer right now, it's very static. We do some biomarker studies, but we just check one biomarker in the beginning of the treatment, and then we just continue the treatment until patient progresses. That kind of approach has been very limited. We wanted to think outside the box. Next. So the patient population that we're focusing on right now is basically patients with incurable cancer. But evolution takes time. So if we have a patient with incurable cancer with no treatment options and 2 to 3 months to live, we don't have time to really evaluate and apply our concepts. So we really have only two criteria: patients with the incurable cancer and have a good performance status that actually allowed for intervention. This is a picture of our tumor board. As you can see that everybody attends, all the clinicians, oncologists, surgeons, all disciplines of usual cancer care team. The unique thing about it is researchers, evolutionary biologists, mathematicians, basic scientists, and clinical trial team. Next. I will hand over the slide to Damon.
Thank you so much, Christine. And so continuing this introduction, the ETB, the Evolutionary Tumor Board, is conducted in a prospective manner. As she described, we take patients with not great options and incurable, but with still some runway, still some interventions that are expected to cause some dynamics to the tumor to enroll patients. And we do this in a prospective manner. So we follow the patients over time collecting further scans, further blood samples, and other things to see how our interventions and perturbations have affected the cancer. Next slide. In a figure form, patients are consented, as would, they're presented their typical options for care, so-called standard of care, available options, and we engage in a discussion, and Evolutionary Tumor Board is offered to these types of patients as well. Should the patient choose to consent, then the patient information is gathered and the patient is presented in the Evolutionary Tumor Board. I'll go into that a little bit further. And then we measure the outcome over time. We gather correlates over time, designed to evaluate resistance biology, and Mark later on will talk about math models. This is all based on principles that Joel will do in a couple slides. The main next slide, you see that there's the ETB recommendation or not in the bottom of that last, and that is the primary objective. So this is a clinical trial. So what are we trying to do? What we're trying to do is to see if we can add to the oncologist's available options for the patient. I may tell a patient they can do IV or by mouth chemotherapy, and also present Evolutionary Tumor Board, and Evolutionary Tumor Board can come up with a novel idea. We bring all the ingredients of what is possible, and Evolutionary Tumor Board might combine those in a different way, change the schedule, or come up with a different idea. And so that is the primary objective. And we aim to come up with a new idea from Evolutionary Tumor Board in 3 out of 4 patients. That's the statistical model that we set up for success of the Evolutionary Tumor Board. There are many non-powered exploratory objectives that have more descriptive stats attached to them. And that includes, once the idea is presented at Evolutionary Tumor Board, does the oncologist listen to that? Do they present it to the patient? And do we ultimately pursue the strategy discussed at Evolutionary Tumor Board? And so determining the rates of adherence to the plan, exploring if they change prognosis or if they do better than the oncologist would have guessed the patients would do, are all currently exploratory objectives, along with building and refining mathematical models, analyzing scans in more productive ways to get more data off of radiology scans that have been collected, going all the way back to the patient's diagnosis and through their journey on Evolutionary Tumor Board. Again, some biology, and then also to generate impact hypotheses that go in all directions. Preclinical scientists are involved, and they may take an idea from ETB and take it to a plate or to a mouse or to their labs, or this may inspire clinical trials in the future. Next slide. There's quite a bit of work. It's a little bit different than a normal tumor board in that rather than just show up and say, I want to talk about this patient, we do quite a bit of digging beforehand. And so there's, if it's a new diagnosis, a lot of discussion, multiple meetings with the oncologist and multidisciplinary oncologist and this huge and fantastic multidisciplinary math and biology and ecology team towards getting all of the data together. This includes volumetric assessments of tumors, measuring the quantity and size of the tumors, biomarkers and available therapies, getting that with literature review and getting a sense of what dynamics would be with standard of care. And then putting this all into a worksheet that Mark will present later, creation of a mathematical model, and oftentimes supplementing the individual patient with a cohort of like patients, and then the presentation in Evolutionary Tumor Board. And with the next slide, I hand it off to Joel. Oh, the last thing is that we do this about monthly. And so far we've been doing this for about 1.5 years, and we have 17 patients that we've consented. So we've been right on target. Joel?
Damon, thanks. And what I want to do is just briefly run behind kind of the integrating of ecological and evolutionary principles from sort of the natural world and cross-talking with the cancer world. I think one of the wonderful things about the Evolutionary Tumor Board was breaking down the Tower of Babel and eventually developing an understanding of what each of us was talking about. So this notion then that when we speak of evolution, that this represents some sort of change in the heritable characteristics of the cancer cell population, whether it's changes in the frequency of sensitive or resistant cells, or whether there's some quantitative trait representing resistance that is sliding up or down. Furthermore, the whole notion that the tumor microenvironment, all of the interactions that may be going into play in terms of how the cancer cells are responding to and influencing their environment, really kind of wraps up what we think of as ecology. And since the focus here is on trying to forestall or manage or prevent resistance while maintaining the sensitivity of the cancer to drugs now or in the future, this provides a chance to apply kind of evolutionary ecology, in which we're really looking at the adaptations of the organisms to their environment. Next slide, Mark. And so in a sense, we're dealing with fit of form and function, but in the form of resistance, and that is the cancer cells can evolve adaptations. Furthermore, they exhibit phenotypic plasticity that can often be built into the models. And we often see the evolutionary process of cancer cells first acclimating and then adapting. Next slide. And what it amounts to as an evolutionary ecologist, and Charlie, you'll probably enjoy this, the other evolutionary ecologist, is just like nature, what we see in cancer is probably a rather dull subset, although a frightening subset of what is evolutionarily feasible and what is ecologically acceptable. And that drives most of the models. Next slide. So a standard model of a community of cancer cells, if you have diverse types, could be Locked-Volterra competition equations. We have population of cancer cells, intrinsic growth rate, carrying capacity, or not. And then some sort of mortality rate that may be influenced by the therapy. And there may be competitive effects, frequency-dependent effects among the cancer cells. Next slide. And this leads to how is the therapy itself disrupting the ecology of the cancer. So here's an example of just one model of where the therapy kills cancer cells based on the dose, intrinsic resistance, and then this V being, in this case, a quantitative resistance strategy. And then how effective is that resistance strategy in reducing the drug efficacy? Next slide. Lots of ways of modeling that. And so this leads to evolutionarily informed therapies, which is really using models and measures of the past and present state of the individual patient's cancer to try to anticipate and steer the ecological and evolutionary dynamics of the disease and to be able to digest the time course of the therapy accordingly. So this is kind of the pipe dream that we're aiming for. And this is what we're beginning to in time operationalize. Next slide. There's really two that we often refer to. One is extinction therapy, kind of a kick them when they're down strategy. Can you have a therapy that drives the cancer cells to NED, clinically undetectable, and then follow up quickly with switching off of therapies with the goal of getting under this concept of minimal viable population size. Next slide. This idea of the first and second strike then is the first strike drug is used only so long as it is driving the cancer cells down. You do not wait till progression. And then upon reaching what you think is the nadir or close to the nadir, you follow it up with second strikes. And these can be multiple second strikes. Next slide. And in this particular graph just shows the standard U-shape sort of trajectory of almost any therapy. You have a single drug, we're imagining sensitive and resistant population cells. Over time, you apply the drug, you get a response, period of remission, and then progression. Next slide. But imagining different modes of action and whatnot, what happens in this particular cartoon that you are seeing is if you apply the second strike, that those two arrows, and Mark, if you can play it one more time, those two arrows, if you give the second drug within those arrows in this particular model, cure is possible. Give the drug too soon as combination therapy, and it will eventually get a good response, but you will get co-resistance to both. Give the therapy too late, and you give time then for resistance to both drugs. And so this extinction therapy is built upon these windows of cure. Next slide. And then adaptive therapy, competitive release therapy is the other therapeutic strategy that we discuss a lot. And based on principles of competitive release, the idea is that you wipe out the sensitive cells, that releases the resistant cells from competition. They take over and cause disease progression. Next slide. So the idea is not to drive the disease below detection limit. In fact, to keep track of where the disease is, but maintain enough sensitive individuals in the population to act as your therapy for the resistant individuals, modulating on-off cycles or dose modulation. Next slide. Mark, those are the principles behind what we do, and then Mark will tell you how we can actually use them.
All right, thank you, Joel. So I'll talk a little bit about some of the mathematics we've developed to track the patient data and analyze both their earlier time course of disease and also retrospective cohorts. And in general, we've taken the most simple parsimonious approach that we can take given the types of data that we have in the different diseases we've looked at. So in the current example, we'll be looking only at imaging. So these were volumetric images that were taken over time and for all different lesions that were identifiable on the scans. And the mathematical approach we've been using is what we term this GDRS model. And essentially that encapsulates the four main dynamics that we see in cancers that are responding to treatment to some degree, but then eventually relapsing and perhaps then being re-challenged with earlier agents. So the G is for the growth. So we take the simplest tumor growth model, which is exponential growth. The D is for death due to treatment, and each agent will apply some sort of reduction in growth, hopefully negative growth, meaning the tumor will regress over time. And then we have the R, which is the acquisition of resistance to different therapies. And then the S is resensitization, which means if you haven't seen a therapy for a while and you re-challenge, you may have more efficacy than you did at the end of the last course of that, or it may be still fully resistant, of course, if it acquired that early in a more permanent fashion. But essentially with these four kind of parameters, we can control the fitting of the volumetric changes that we see in the patients. On the right, we have an exemplar patient taken from one of our ETB patients. And the vertical solid line is when we first consented the patient, and we're going to discuss them in the Evolutionary Tumor Board. So everything you see in the different colors there to the left of that line, that's all previous scans that had already occurred before the ETB. So we first go back and essentially radiologists will look at every scan that was taken, and instead of just looking at the recessed diameters of a few target lesions, they'll look for any available disease that is present and also measure it in 3 dimensions to get a more accurate volumetric scan. And that's what's plotted here on the vertical axis. Note that we're on a log scale, so order of magnitude changes are the types of things that we're looking at here. And all the dots represent the detection of a particular lesion at that particular time point. And then the lines represent some example fits that come out of the model that I described on the left. And so you can see kind of the types of behaviors that we get. So the growth is shown here before the first treatment was administered. And then there's the death due to, in this case, cisplatin, which was administered. And then you can see this kind of bottoming out or U-shaped nadir, which is reached as, in this case, resistance to cisplatin accumulates and eventually the efficacy is lost. And then treatment was stopped, so we assume that the tumor will begin to grow and so forth through this. Now, there are many ways to fit these 5 or 6 data points for this primary mass to fit reasonably well with different parameters. So this is just showing one particular example. Of course, without scans in here, we don't know exactly what happened, but this is one possibility that the mathematical model suggests. And then over here, we have some metastatic lesions that arose following the radiotherapy that was received to clear out the bulk of the primary disease. You'll note this horizontal dashed line here. That's kind of what we call the detection limit of the imaging instrument, which is roughly going to be 1 millimeter or 2. And so this first clump of points here, which represents some lung and lymph node metastatic lesions that appeared later, in fact, were not detected on the scan. So they're all marked as X's below this line saying there was a scan at that time, but careful inspection, even knowing where the disease was later, doesn't reveal any apparent disease. So we assume that the disease was there, but it was some size smaller than the detection level of the instrument. So even the lack of information in this case can tell you something about potential growth rates. In other words, if this was undetectable at this time point, but then was a size of a little over 1 centimeter cubed at this point, then we can sort of put some sort of lower limit on the expected growth that might have occurred between those 2 points and so forth. Then on the bottom, of course, we have the different treatments that were received at different times. And at the time of this patient being consented to the ETB, they were receiving, they'd recently started cetuximab and nivolumab combination. So how do we then go ahead and make some predictions for the patient? Well, the first thing we do is to collect a retrospective cohort of patients with the same disease and looking at the types of dynamics that they had for the different therapies that they received. Now, obviously, every patient's going to have different therapeutic courses. So here's 4 examples of other head and neck patients from the historical record that we analyzed. And so you can see some received this cetuximab nivolumab combination towards the end of their course of therapy, and others received it, early on, and so forth. And so these historical cohorts, we also go back and treat them as we do the ETV patient, meaning a radiologist will go back and look at every scan and expand from a basic one-dimensional RECIST criteria into full volumetric measurements of every available or detectable lesion that we see. And then we apply mathematical modeling, as shown before, to these patients to extract the types of parameters that we see in this group of patients that have, similar disease to the ETV patient. So we'll see, what's the fastest and slowest growth rates we're seeing in these patients? What is the response in this case to cetuximab and nivo that we saw in these patients? Some respond well. For example, the upper left seems to have a decline in tumors. Others don't seem to respond much at all, and they're either flat or maybe are even progressing through that treatment. So you'll get a large range of responses from that. But what this gives us is kind of a prediction cone. So we're here in Florida, and so we often see, a lot of hurricanes coming by, and thankfully they often don't hit Tampa directly, but sometimes we're in the cone. And so that means, preparations have to be made. And so the question is, how do you know if something's going to go in a certain direction? And so the idea of prediction cones means we don't know exactly how this patient's going to respond to cetuximab and nivolumab combination a priori. There's just too much variability to know that. So based on, looking at what other patients have done in response to that combination, we can put a very wide cone, but a cone nonetheless, on the potential outcomes of this patient. So that's kind of the widest cone here. It says if we take all the historical analysis we've done of other patients that received this combination, you kind of get the best and worst case scenarios. And so they're going to be most likely somewhere in between those scenarios. But what's interesting in this patient, they actually received both cetuximab for a short time and pembrolizumab, which is relatively similar to nivolumab, previously. So not only can we use historical data, but we can also use some of the information, which is admittedly sparse, but there's something there in terms of how they responded to those brief courses of those therapies. Now it's confounded by the fact that they were also receiving chemo at the same time, as opposed to now when they're not. But again, the mathematical model will go through all possible reasonable fits and extract a cone, again, for the efficacy of cetuximab and nivolumab based on not only the historical data, but the patient's own previous data, if they had received that drug before. So that kind of secondary analysis of the patient's previous response gives us this patient fit prediction, which compared to the average patient in the historical cohorts we looked at actually looks quite a bit better than the average. So the model would say, right now, since we have no data points, imaging points on the current treatment, which was recently started, the wide cone is kind of like the biggest range of behavior. And again, on a log scale, this is a huge difference, 4 orders of magnitude of response after a few months. But additional analysis of how the patient previously responded and the length of time they were on there and how the resistance kind of shapes fit suggests that they likely are going to have some decent response to cetuximab, nivolumab. So, was there a decision to be made as far as the treatment right now? Well, not really, because it would say you should definitely stick with this because it's likely to be effective. So the question, though, was eventually it's thought that the combination is going to fail and they will start to relapse. But when will that occur? And at that point, then we'd want to switch to something else, right? So in this case, a couple of different chemotherapy combinations were the follow-up option for when this targeted immune combination failed. So that would be the question of, assuming the first strike is the cetuximab nivolumab, when would you then switch to your second strike? And as Joel mentioned, you kind of want to do it when your efficacy of the first strike is starting to run out and the tumor is starting to flatten out, reach that nadir, and then before it starts to progress, certainly. So that's where our subsequent analysis comes in. So in this case, we waited a few weeks to get the scan, which was scheduled to arrive, on standard of care scheduling. And indeed, in this case, the patient had a significant reduction. I mean, still a very detectable lesion. And there are other lesions here, which I'm not showing just for clarity of explanation, but there are other lung and lymph node lesions as well. And the mathematical model looks at all the lesions. But essentially, the response was significant to this combination. And so again, we can use the model to say, well, is it time to switch, right? Because again, we want to switch before we see the U shape actually in the imaging. We want the model to predict when the nadir is approaching and then make the switch, hopefully just right before that, to extract maximum efficacy from the first strike, but then not wait too long to switch to the second strike. And at this point in the analysis, the math model suggested that the efficacy ongoing of the targeted combo would be at least as good as switching to the chemotherapies available. And again, since they'd seen these two chemotherapies, these two combinations of chemotherapies in their primary disease course, we have some specific patient-specific information as well as historically derived cohort information about how we expect these may work. And so in this case, the decision at this time of the ETB was to continue with the cetuximab and nivolumab because likely there's still room for one more scan, at least, before the patient would start to potentially fail, reach a nadir. And so that's what was proposed. And so on the right now in the orange square, we see an additional follow-up imaging point. And so we rescheduled another ETB, so to speak, to discuss this patient. And you can see that there was continued response, but it certainly seems to be flattening out. And so now you can see the same analysis with additional data and additional time has changed the prospective predictions of, should we switch to our second strike or not? And so at this point, the model has shifted from earlier saying, there's unlikely to be any benefit. In fact, you may lose some efficacy overall if you switch now, but now it's saying it's most likely to be beneficial to start thinking about switching to those chemotherapy combinations. So in our second vignette here, this is looking at a slightly different approach in which we're looking at earlier stage of treatment. So there's much less information on this patient. And this is kind of an illustration of where we want to take the ETB for making earlier kind of interventions in the process. And so in this case, we had a patient with Ewing sarcoma. The first strike, as shown on the right, appeared to work very well. So, a very large primary tumor in the hip region was reduced to kind of a very thin mass after several months. And on the log scale, that's shown here on the left. So they were receiving a combination of 5 agents, which is standard of care. And then there was a significant reduction, about an order of magnitude in total volume for the tumor burden. So here we have this concept of the phase I trial, which is essentially the I in this case stands for imaginary. So it's something that we do virtually inside of virtual patients using mathematical modeling and kind of first principles of, resistance and drug response and so forth. So we use the same model I showed earlier, and essentially every parameterization of that model, so fast growth versus slow growth, high versus low drug efficacy, fast versus slow acquisition of resistance, all those combinations of those parameters form what we call different virtual patients. And they're different because they respond differently over time to any particular drug regimen that you apply to them. So here we take essentially this 5-drug combination as kind of our first strike, and we apply it to a range of virtual patients. So it's kind of represented by this cube, if you will, on the right, where you have some fast and slow growers and high and fast and slow responders, fast and slow resistance. And we apply the same regimen, this 29 weeks of this BDCIE, and we run a clinical trial in these virtual patients. It's about many thousands of these parameterizations make up the cohort, and that's shown here in black in terms of how long it takes for the different instances of the model to progress. And we use the same criteria that we would see in a typical clinical trial. And essentially, we measure the model outputs using RECIST, assuming that there is, in fact, a detection threshold of the tumor size, right? So that, if you have progression with micromets, you wouldn't detect that because you wouldn't be able to see it on imaging yet. So that would kind of delay progression in some sense. And, the 20% RECIST criteria from, successive scans and so forth. And we apply imaging to the model roughly at the same rate that would typically be done for these patients in clinic, which is once every several months. And if we do that, we can compare it to an actual, progression-free survival curve from a recent trial. In this case, the AEWS 1221 in Ewing sarcoma, and that's shown in blue. And so that's a few hundred patients, I believe, 100-something patients. And so we can basically fit the virtual trial to start with to look like, to have a similar PFS to actual clinical data. Now, to be fair, there are many clouds or blocks or cubes of virtual patients that can generate similar curves, but it's actually not as free as you might think. So these three parameters of growth, death, resistance, they have some critical effect on how this shape looks. There's this kind of early period of like non-progression followed by this, this inflection point. So, and you can also argue that the model is too simple to really capture the nuanced disease changes that are occurring in Ewing. So there might be an aspect of that. There certainly is. But the goal here is to kind of illustrate more the approach that we want to use going forward to analyze these patients in terms of these virtual cohorts. So again, here we had this kind of calibration phase, which gives us the entire cohort in black. And then what we do is we say for this patient, number 15, which is we're discussing, we have the first follow-up scan following the initiation of therapy. And we saw that there was a 90% reduction in tumor volume for total tumor volume. And so that kind of looks like this on the right. So if we start with a relative volume of 1, then the first scan, which is in blue, should be at about 10% of the size. And so what we can do is look at all the virtual patients that we did, 16,000 or whatever that created the black curve, but only select out the ones in that cohort that also match that first scan point. So how many of those patients in those 16,000 have a roughly 10% reduction in tumor volume at day 79? And again, we introduced some sort of error, the allowable error, right? Some allowable tolerance, so it's a small cluster of patients that roughly look similar. But what's interesting is you can see there's a pretty wide variety in that sub cohort of patients. Some of them decline very quickly, reach the 10% mark at day 79, and then we're already progressing at that point. Whereas others decline a little less quickly, go through the same volume at day 79, but actually continue to decline. In fact, don't have progression for several years. But anyway, if you take all the patients that are in that clump, here's kind of a look at that, right? And so you can see already we're getting our prediction cone, and it's very wide. Some patients may progress very soon, or in fact be progressing already at the time of discussion, and others, again, may last several years. But if you take this entire cohort and run PFS just on that, you see the red curve, suggesting that this particular patient has a more aggressive disease than the average patient that was seen, for example, on the AEWS trial. Again, all these are with the same 5 agents to begin. Now, what's interesting as a side note is that if we had an additional imaging point, if we go back in time and say, let's take a 6-week scan of this patient, that would help immensely to try and decide where in that giant mess of spaghetti they actually lie. And so if at 6 weeks they had received a scan, which was here in the red point, then we would kind of say they're going to be progressing soon. Again, also assuming that they received the blue point. So if they gotten red-blue, we could say with much more certainty that they're very likely to be progressing soon. Whereas if they'd received green then blue, we could say there's probably some time before there's a chance of them having some progression events. So just to wrap up this vignette, the question was asked, what would be better going forward for patients that are receiving this treatment? So, in terms of that actual patient, what to do next, that's more of the analysis like we showed in the previous vignette. But then going forward for additional patients that have, this situation, what's the best thing to do? So this is the situation with standard of care. And then the question would be, if you wanted to make a significant improvement in outcomes for event-free survival, and Damon, who was the oncologist for this patient, suggested, tell me how much better this 5-drug combo would have to be in terms of efficacy to get 17%, improvement in, 5 years event-free survival. So that's what's shown here. So basically the model suggests if you across the board could find a treatment that was 40% more effective than this 5-agent combination, which is a significant jump in effectiveness, then you would get your 17% difference here at the 5-year mark. You would also significantly, increase the progression-free survival of our particular patient, number 15. But actually still, even with that level of a increase in efficacy, it's very unlikely that they will not have progression before the 5 years. Again, this is assuming the assumptions that we made earlier about the model and data, but this is the types of analyses that can give some insight into what we're looking at. So 40% increase in what's already a very extremely, heavy combination of chemotherapy agents is, hard to imagine in the short term. So instead, again, going back to these evolutionary principles, what about the second strike approach? So again, we have our standard of care here, which is 29 weeks. And so what's interesting is that the model says if instead of trying to make your first strike better, just use your first strike as it is, and then apply. And in this case, I chose day 110 because that's about when the patient was enrolled. So if on day 110, you have the information you have, and you can switch to a second strike, what would you need to get that similar 17% increase in overall cohort, 5-year survival? Well, it only has to be 71% of as effective as the first strike. Meaning you can either look for kind of a novel agent that is going to be 40% better than this 5-drug combination, or you can use the existing standard of care, but just switch early to something that is 70% as effective as that first strike, and you can get the same types of outcomes on the cohort. And that leads then, as Damon and Joel has mentioned, we say first strike, second strike, but we really mean second strike and third and fourth and fifth as necessary. And so what about a third strike, right? Say we wait another 3 months and move to a third strike and then potentially, because there are numerous agents that are available for, Ewing's, but generally this is 5-drug combination is shown to be, somewhat marginally better than the other combinations. But, and again, we could discuss cross resistance and the similarity of agents, but essentially if you could make a sequence of these agents, they don't have to be all that effective. 71% is a reasonable estimate. They don't have to be as effective, and yet they can produce significant improvements to the PFS. Okay, so just to conclude, we basically are incorporating an individual patient data, historical cohort data, the knowledge that we gain from basic science, evolutionary biology and the principles of ecology, and mathematical modeling. And the attempt here is to provide dynamic decision support to the oncologist to, kind of provide a deeper insight in terms of what the patient is doing between scans, and also what the potential is for progression, acquisition of resistance, and how switching to different therapies or doses or regimens may impact their outcomes going forward. And I think, we've identified, we kind of knew going into this, but we've continued to realize and know that the greatest need is always for additional retrospective data so we can do a deeper analysis of the dynamics. So in that first vignette, we were looking at the combination of cetuximab and nivolumab, and, we had a recent clinical trial looking exactly at that combination. But for other combinations, which either have been standard of care for longer or less, researched at this time, there may not be the same quality of data, or we have to go looking for those as well. So for each combination of drug in each disease site, we need a number of patients to kind of look at what's the range of behaviors we see. We envision, perhaps 3 phases of the ETB. First phase is kind of what we're in now, which is development. So we're, curating cohorts, identifying which biomarkers are relevant, developing the mathematical models that are specific for each disease, coming up with the workflow that informs, in a useful way, the oncologist, what may or, may be options going forward. And right now this is done at the moment entirely at Moffitt, but we're looking at some other select sites to join us in this development process. The second phase we envision is moving as these mature in individual diseases, we would hope to move those into clinical trials to test out the approach, in a powered way, looking at outcomes and et cetera. And those we hope will be multi-site trials. And then eventually if we encounter something that is validated and, provides significant improvement, then hopefully that could be moved into standard of care. And that would involve, obviously, scaling up the approach and making it more automated via software and so forth. And kind of behind a lot of the work we've done, we have a Center for Excellence in Evolutionary Therapy here at Moffitt. And the goal is essentially to support this approach, which is to look at how we can use evolutionary principles, mathematical modeling, and basic science research to translate into the clinic in a very dynamic fashion. That's the key, is that everything is dynamic. You continually look at new data as it comes in and alter your predictions on the fly, rather than using kind of we look at a biomarker at the start and then we prescribe treatment until it fails. So the COE, Center of Excellence, supports a lot of angles here. So the key one is that we're a very integrative center. So as Christine mentioned, there's, oncologists, people from the clinical and research side constantly working together. We have pilot awards, grant support. We have a conference, which some of you may have attended a few years ago before COVID here in Tampa, and we're planning another one. Clinical trials and adaptive therapy have been, initiated, and other evolutionary therapies as well, and supporting the ETB and so forth. And we do have a monthly seminar series where we welcome speakers from anywhere. So if you're interested, please do reach out to us. And this is a massive team that is, worked on the ETB for the last year and a half and prior. So lots of disciplines coming together and lots of people contributing to that. So thank you very much.
Thank you very much. That was fantastic. Thank you, Damon. Thank you, Christine. Thank you, Joel. Thank you, Mark. That was really great. I wanted to just say a couple words and we'll open it up for questions. First of all, the papers you guys provided were fantastic. I sat down late last night. I thought I'd have time to just skim them, and I ended up staying up very late reading both of those papers. They're fantastic. I think the Read It All one I'm going to use as a paper in my evolutionary medicine class. It's a really great introduction to these concepts. And suitable, I think, for that class. The other thing I wanted to say is I really appreciate all the Duke people who showed up today and other TRISEM people. We've got such a great turnout today. And I just wanted to recognize that. And I hope you guys have lots of good questions. I've already seen a couple in the chat. I'm going to turn things over now to Meredith to handle the questions. Oh, good. We have a hand up already from a Duke faculty member.
Yeah, so go ahead, Will, and other people. There's a lot of great questions in the chat. Feel free to raise your hand to get those prioritized, and we'll try to get as many answered as we can. Go ahead, Will.
Oh, gosh, thanks. Sorry if I'm leapfrogging the chat questions. Guys, that was a really, really wonderful talk. Thanks for taking the time to do it. I was actually just curious, the extent to which you're getting the pure clinicians engaged in this. Do they kind of send you the details and have you run through this, or do people show up and participate like at a conventional tumor board? Can you comment on the dynamics of it there at Moffitt?
You want to do it?
Yeah, so the clinicians are quite involved because not only just presenting, it involves digging through all the clinical treatment history and getting pathologists involved. All the old imaging studies needs to be revisited because, as not all the lesion gets reported. So it requires massive amount of time from the clinicians. And in the beginning of the ETB, there were lots of different organ sites participated. And over last year and a half to 2 years, there has been a bit of a dropout from the clinical side because it was just so clinically intense. But as we automate these steps a bit better, I think we are going to get more clinician involvement. But it's not like, lots of clinicians to show up. There are a few clinicians which are really invested in understanding this approach. and those, hardcore people show up and things move forward. Damon, would you like to add?
Yeah, we've developed a bit of a system, a primer for a new oncologist, for example. So the breast cancer team is getting engaged with this now, and so we first met over at dinner. Then we have a slide deck now for here's what you're getting into, but it is not like a traditional tumor board where the oncologists show up prepared. I think that there is quite a bit of dialogue that goes on beforehand, which I would estimate at like 6 to 8 hours time on the oncologist side, and a lot more time on the IMO side, pulling literature and building these models for cancer specifically, which all have different dynamics, different therapies, different roles for radiation surgery, different metastatic routes, different rates of growth. All of those things need to be kind of parameterized on an individual cancer level. So we try to most of the patients have been head, neck, and sarcoma. But we do go out. There's been a lung cancer patient, which was not the best experience, and metastatic breast cancer, we learned the lessons, and it's getting to be a better one.
Cool, thank you.
Great, thanks so much. Next, we'll go to Andrew Reed for a question. Andrew, go ahead.
Thanks very much, and thanks for an outstanding presentation, really stimulating. I can see that when you get to the randomized control trials, it will be easy to see if this is working, but I wonder if you could speak to how you know if this is working before you get to the randomized control trials. If you've got 17 patients now, how do you know you're making a difference to any of those compared to standard of care?
We don't quite know yet, because as you can see that our protocol is a feasibility pilot study. So one way of knowing whether the current patient works or not hinges on historical control. So that's why we needed to have a significant retrospective data to be able to sort of see relatively how my current patient falls in within the historical control. So first phase is whether we can make the model and can we gain some additional information, and then we'll follow current patient prospectively to see whether what we modeled is true or not. But we don't have enough body of data to show this will actually improve survival as conventional clinical trial would do. Damon?
Definitely a future step is efficacy, but right now, try to convince me as an oncologist 3 years ago that my chemo that was shrinking a tumor is something that I should stop and move to something else. That would have been impossible. But now I know it's absolutely the right thing to do. And maybe even stopping therapy is the right thing to do if I know the future is that this patient's going to develop resistance and I have no other options to give. And so we've had to do the incredible work of learning each other's language, understanding ecology and dynamics, understanding that resistance in minor populations may matter more than the large populations up front, learning that the assessment up front is not as important as the assessment over time. That's the steps we're at. Mark, I'll turn it over to you because you've been thinking a lot about how to make this more towards that question. What are the next steps, future of ETB?
Yeah, I think obviously with the numbers we have and even the way we do the ETB outcome comparisons be very difficult, with any sort of not even close to power really. So one of the things is, as you saw in the kind of model presentation, the model doesn't say we expect the tumor to decline by 86% at the next scan, and then we check, okay, yeah, it was. Often you get these very wide cones that then shrink over time, and so we can ask, did the patient fall within the predicted cone, and that's something we definitely are investigating. But if they do, it's not clear, what that means in terms of, the actual philosophy of the ETB, which is to change treatments based on that. So that will require more like direct outcome comparisons. But then, like Christine said, we need historical cohorts. We need to see where they fit in those cohorts. And, that's starting to look at more trial approach rather than what we're doing here. But that is definitely something we're interested in. So like in parallel to these developmental, sandboxing, pipeline workflow things we've been doing with individual patients, we're also developing more robust tools to do a lot of this analysis in a more rigorous way for that reason, so that later we have, very precise control of what is being predicted and in a statistical manner, right? So, right now I show these curves and it's very hard to show them on a two-dimensional plot because, they're really clouds of probabilities that are weighted, and so the end should be much less likely than the center because, it's usually some sort of normal distribution to the response, that kind of thing, or what have you. So it's hard to show that, but essentially that is the approach we take kind of under the hood, which is everything is weighted, everything is probabilistic, and then you come out with kind of these cohort predictions, which can either boil down to, yes, it's likely to be better to switch or not, or we could delve into that more carefully to say, how close did we get, if we assume the uncertainties that we know both clinically and mathematically.
Great, thank you. So next we'll go to a question from Joe Graves. Joe, you can go ahead.
All right, so you guys might want to excuse me for asking a naive question. I actually don't know how or the mechanisms of specific cancer drugs. But one question that I proposed is, would you be able to have more effective hits if you were using drugs whose actions were antagonistic? In other words, if the tumor cell got better at resisting drug A, it was simultaneously getting worse at resisting drug B. Now we know this works in bacteria because my work is in bacteria, and we know that you can create antagonistic combinations that lead the organism into essentially an evolutionary trap. In other words, it can't evolve its way out because getting better at A makes you worse at B. So I don't know if that exists in the cancer world or not.
Well, I would like to just answer a quick question in terms of a medical point of view. I mean, we talk about first strike and second strike, third strikes. As a treating physician, what I struggle the most is number one, timing. As Joel mentioned, timing is the key. So you don't develop resistance to both drugs, all that. So when do I switch? It's really unnerving for a treating physician to stop a treatment that I know it's working right now, right? So you have to have, great predictability. You have to give me confidence that it will develop resistance soon. You have to switch. Second is, what is the best drug? That's exactly what you're asking. You're asking, what is the best drug combination? What is the best first strike? What is the best second strike? In theory, second strike, we assume that it will work, even if like 70%. In head neck field, second, third option, it's like response rate of 5 to 10%, not 71%, not 90%, not 104%. So I would love to hear Joel's and somebody else's idea, to treating physician, how can we predict what would be the best second or third strike and when?
Yeah, so speaking to that, and Christine, I think you're spot on in terms of the issues of operationalizing this. And Joseph, speaking to your point, we're developing, and others, even people on this call are developing them, kind of a library of the types of interactions. Some of this is a wish list. Some of it really requires a lot more knowledge of pharmacokinetics. It's going to require other things. But right, as you saw, we had the extinction therapy, first strike, second strike. We had the adaptive therapy. We also have evolutionary double binds. Those would be your antagonists. The idea that can you apply a drug that not only has a novel mode of action, but in fact, the evolution of resistance to the prior drug actually sets it up. My favorite as a game theorist is to try to create a group sellout. Can you actually, like that Far Side cartoon, get the bear in the gun sight to point to the other bear? Can we actually create a therapy that exploits the aggregation effects of the cancer cells to, in essence, get them to throw each other under the bus? You also touched upon an evolutionary gambit. Obviously, right now, Christine is going to say, well, that's cool if you can prove it works, but I'm not about to subject one of my patients to this, and that is that evolutionary gambit. Can you actually do something that you know is knowably going to make the tumor happier, realizing that you're leading it into that evolutionary trap? So I'm happy to report that, yes, it is on our radar screen, this kind of whole suite of figuring out diabolical ways to interfere with the cancer. And then it hits the reality that Christine and Damon will say, that when you hit the trenches and the knowledge that is actually known about combining these drugs.
Great, thank you so much for that. So we are running close on time, but I know we have a couple more questions. Vaughn Cooper, you had your hand raised. I know you just posted in the chat, but do you want to ask that question quickly?
Yeah, sure. Thanks, Meredith. Just super presentation. Just wanted to say we enjoyed discussing some of your work in our EvMed course here at Pitt, and the students loved it. Lots of questions. So maybe we'll get you guys to come speak to the students in a couple of years' time when we offer it again. The real question is about culture, and hopefully you can read it in the chat. I'm curious if you have any broad recommendations about your experiences and sort of setting the psychology and the culture of your group so that they're willing, so that you might be willing to consider stopping a treatment as Damon suggested, that is apparently working because the models indicate that it's the right thing to do.
I have often allowed the patient, if you really listen to your patients, they'll tell you what they want. And a lot of my patients tend to be younger, but I think they're if we were to plot they ask questions. Some of them are Ivy League students, some of them are electrical engineers, some of them haven't gone to college, but they ask questions. And so they say things like, why wouldn't we go back to what worked 3 years ago? Which is not what I would normally do. I wouldn't give a first strike from 3 years ago again. But that's like, oh, I don't know, maybe we could see what the resensitization rate is. And if you're really up for IV chemo when you might only have 6 months to live, then you're a patient for ETB. And do you want a squirrel biologist to talk about your cancer? Yes, I do. Okay, you're the right person to go on to ETB. And so generally when I'm talking to patients and they don't like the options and they want me to dig a little bit deeper, I will introduce ETB, but almost all of the more than half dozen patients have asked a question that made me think of ETB. Oh, I have ETB to offer this patient. And so they've kind of brought it up. They've kind of self-selected in a way, even if they didn't know it. So I would describe it. Hey, we're going to talk about you. We're going to do math. We're going to do all these kind of different ideas. And if I don't like the idea, I'm not even going to present it to you again. But if I like the idea, I'll bring it to you and then you can decide if you want to do it. That is kind of it's a bit of a self-selected group, but they generally ask the question to get it started.
And it is part of our feasibility assessment. Does the treating physician go back to the patient and discuss it? And does he or she make treatment changes? We're not imposing to make a change, but if they do, we record it.
Yeah, and my curiosity has been to move it up front, as Mark showed, with patients like, celebrating this first response, a good first strike, but knowing that inevitably their disease is probably fatal, trying to see other, not just the last 6 months of life. It seems to have been fruitful so far.
Thanks very much.
Thank you so much. So I know we're at time, but we're going to try to squeeze in one last question from Amjad Dabi. Amjad, you can go ahead with your question.
Hi, yes. Thank you all for a wonderful talk. I sort of wanted to take a step back and I was wondering, in terms of like a molecular level of an understanding of the evolution of cancer, what are some of the bigger questions that are still really not answered and that may actually be really important for a kind of translational clinical understanding of this interface between cancer evolution and treatments?
So many, like anything that happens with cancer tissue after diagnosis, after the diagnostic biopsy, to me is the answer to that question. Anything that we can detect in the blood over time to see the dynamics of cancer is the answer to that question. And it has not traditionally been the focus. And when I go to ASCO next week, we'll talk about, biopsies up front and molecular characterizations, and we'll sequence and we'll go deeper. We might even do single cell. But that picture at diagnosis is fine, but only for a limited period of time. And it, I'm increasingly convinced the minor clones are what determines my patient's outcome, not the major ones. We have good therapies for the major clones. And so it's all of the changes after time. It's resistance management. It's anticipating things. It's learning from failure. The things we don't do in oncology very well.
And I think if I can just add to that, I think there's that chasm between what's happening at the molecular level and what it really means to the fitness of the cancer cell. I think what gets lost, we measure things about the whole tumor, the biomarkers, we measure things about the molecules, but we actually never actually walk in the shoes of the cancer cell itself. What does it experience as its opportunities and challenges? What are its problems and opportunities? And those are what we want to exploit. And so I think anything that enhances biomarkers that are accurate, anything that enhances biomarkers that are predictive rather than, we really need leading indicators, kind of like in economics, we really need leading indicators. A lot of what we measure is when the bad thing has happened, we know it because the bad thing has happened. And so I think molecular biology, histology, you name it, it's going to be how we can integrate that into a picture of a more dynamic view of how the cancer population is going in its tumor ecosystem.
That's why we have 11 exploratory objectives in our protocol.
Okay, I think we should end there. Thank you guys so much for a fantastic presentation. I'm sure this conversation could go on for another half hour, maybe couple of hours. Thank you very much.
Thank you.
Thank you.
Before we break up, before we end the call, I want to share with you our upcoming Club of Meds. Hopefully my screen is shared here. We just heard from the Tumor Board. As you know, we have another cancer talk on the schedule. We have authors from these two papers published in Nature talking about Peto's paradox. And I hope you all can join us. That's going to be on June 9th at 12 noon Eastern. So with that, thank you guys again for tuning in. Thank you for the great presentation. And thank you, Meredith, for organizing and keeping us going with these. Thanks very much, everybody. Great to see you.